Simon. I'm the director for the Asia Center for Health Security. It's our pleasure to co-host the events of today and tomorrow with a team from Simon Fraser University. And it's our pleasure to host them as well. They've been in Singapore for quite a number of days now. Of course, the question of borders has been very much in the news and maybe on our minds recently. Over the past 2 years, we have seen Russia, Israel, and America, three countries we don't often think of as a common group, trying to expand their territory. Our session is focused today on an older issue, which I believe most of us have been trying to forget with varying degrees of success, which is the issue of pandemics and borders. So we all understand that infectious diseases knows no borders, but nonetheless, human-made borders are a traditional and I guess publicly been a crude line that we draw to try to mitigate the spread of these diseases. The recent COVID-19 pandemic as well has left us with a wealth of experience, but it hasn't always been the easiest to try to piece through all these information and come up with the real lessons versus all the other draws that we get subjected to at a daily level, right? So we do have a lecture from Professor Kelley Lee, who will start off by highlighting all the lessons that we should have learned from the past pandemic. So now it's my honor to introduce Professor Kelley Lee. She is a well-renowned expert in global health governance, and she also serves as the scientific co-director of the Bridge Research Consortium, which supports public trust and equitable access to new vaccines and for pandemic preparedness. She's currently the Tier 1 Canada Research Chair at the Faculty of in Global Health and Governance at the Faculty of Health Sciences, Simon Fraser University. The topic today is Managing Borders During Global Health Emergencies, Lessons Learned from COVID-19. And I'd like to take the opportunity to welcome Professor Kelley Lee.
Thank you. Let's do that. Okay. Good morning, everyone. I hope you can all hear me. I have my microphone on. I think it's working. If you can't hear me in the back, just wave your arms and we can do some adjustment. Okay, it's a little bit of feedback. That's it. All right, that's good. It's still some feedback. Can you hear? Is it me or is it? Yeah, I can hear some. Okay. All right, hopefully that does the trick.
Yeah, it seems like it's okay.
Okay, it's a pleasure to be here, and thank you, Yi-Yang, for hosting us this week. It's going to be, I think, a great 2 days. A lot of you are joining us tomorrow for the workshop. I'm looking forward to meeting all of you. I want to thank my team, particularly Miranda Nonis, who's sitting here, I know a lot of you have been in touch with her on this event, and also my other team members who are here is Julia Smith, at the back, who's now at Vinh University, so here in the region, and Ben Taylor, who's formerly with the Department of Defense in Canada, who will be working with us tomorrow as well. I also wanted to mention Julianne Piper, who's part of our Pandemics and Borders team. And so what we wanted to do, we wanted to come to Singapore to share our research that we've been conducting over 5 or 6 years. This was not even a topic, really, before COVID-19 in terms of really concerted research. The travel and pandemic connection was pretty limited. We didn't have a pandemic, I guess, but travel wasn't figuring very highly in that, in the pandemic responses that we've seen over the decades until COVID-19. And beyond public health, travel has become a bit of a sleeper issue. It was impacting all of us who wanted to travel during COVID. But now when we try and talk about it with people, I think people feel like they want to move on, or this is, we've talked about COVID enough and we don't really want to talk about it anymore. But really we have not figured out the policy lessons that we need to learn from this recent pandemic. And so this is why we're here. We want to keep this issue alive, because if there is another pandemic, and there certainly will be at some point, travel will be one of the key issues that we need to manage very carefully. And so suddenly will be relevant again. So we don't want to let this slip by. So what I'm going to do is, first of all, say a little bit about what we've done, what we've found out, what the evidence is at this point, and then what we can take away for the next time. And so our Pandemics and Borders team, as I say, was formed in 2020. It's been a absolutely busy time, and then now it's gone a bit quiet, but we were funded by a number of funding bodies up there. We're also very interdisciplinary. We're not just a public health group. We were particularly strong on the policy side, so political economy was a big part of our analysis, political science, but also things like genomics, math modeling, and so on. So we really had to have a very interdisciplinary group. And you can see that we're also spread across a number of universities. And the kind of questions that we addressed did change over time. First of all, we were trying to figure out what was going on. It was a very unprecedented period. We had, we had some travel measures being used, of course, over the decades. But when COVID-19 happened, there was a big explosion. I'm going to describe that in a minute. So we had to form our team. But essentially, our research questions were to understand what and how travel measures were used during COVID-19. Just documenting that was very complicated. Every country did many different things differently, so just trying to make sense of that, and looking at past disease events as well. Reviewing the evidence on effectiveness. Does this actually make an impact? Is it achieving what we're wanting it to achieve? And that's not a straightforward question to answer, actually. Given that there were so many different things you've done at different times. We wanted to step back and really just analyze how border management happened. And it was a very complex policy challenge. It wasn't just about epidemiology. It wasn't just about logistics. There was a lot of things going on there. And then really looking forward, trying to support better decision-making now that we've had a really, a lot of real-life lessons. So the landing is on risk-based approaches, which I'm going to talk about. And then finally, this is not just about the evidence, this is about values as well. It's about the equity implications of these policies. These policies landed differently on different people, and we need to better understand that. And so let me take you back to 2019, if you'll all remember. There was a lot of travel. We, in fact, had year upon year of historic levels of travel. Tourism was just going through the roof. We were setting new records every year leading up to 2019. So it was a very different place in the world. Many of us took it for granted that we could just, for those of us who have the resources, we could travel pretty much anywhere we wanted. And you could see this billions and billions of people were moving around for work, for business, for pleasure, and so on. And, there was some uncertainty, but generally we thought this would continue. And then we had this. And so who would have predicted that the world didn't come to a stop, but it was certainly hindered in the level of travel. And, within a few months, or at least a year, we had a huge number of policies that we could not even have imagined we would have across the world. Initially, it was airports, some of them quite empty. We're used to them being busy, bustling places. And suddenly we had, pretty empty, relatively empty airports, but also land border crossings and sea travel. So air, land, and sea, we move about in those ways, and those were all impacted. You remember those cruise ships that had to be docked? They were a major source of outbreaks. And then we eventually moved on to policies for those who were still traveling, and we still needed to have travel. So masking on airplanes, for example, testing, eventually vaccination, and I should have an image here of quarantine, which was also a big part of it. But there are other measures as well, lots of screening, a lot of other activities, a lot of advisories, as we know. So that was what, we pivoted very hard. So how did we get to that point? And in fact, we would have not predicted that would have happened, because if you are familiar with the international health regulations and you were following WHO at the time, the advice on January 30th, 2020 was that the organization, the Emergency Committee, did not recommend the adoption of travel or trade measures based on what they knew at the time. They didn't think that was useful, but also that based on previous evidence, they weren't going to be necessarily effective. but also they can be seen as very punitive. So you can have very significant economic and social impacts of restricting travel. You can also hinder countries from reporting outbreaks or cases if they feel that they'll be punished, because of restrictions. And so WHO did land on saying, no, please do not adopt these measures at this time. And that was restrictions specifically, and that's important. I'll come back to that. And then there was a little bit of softening when a month later, when they issued some more guidelines. They continued to say that restricting the movement of people and goods was generally ineffective, but they could see if that countries could justify doing so based on risk-based approaches, then there may be a case. But those are usually in the most, last resort kind of situations. So that was the received wisdom at the time. But this is what actually happened. So did countries take WHO's advice? Well, generally, no. There was a complete actual opposite of what WHO recommended. So what this graph shows is that all the new measures that were adopted over the first year or so, first maybe 10 months of the COVID-19 pandemic, and where the sort of WHO statements are. So you have the declaration of the public health emergency of international concern, January 30th. A month later, the updated recommendations. And then the significant, at least politically, statement that COVID-19 was declared a pandemic. In all of those cases, what you see is a spike in travel restrictions. And that is, as I say, opposite to what WHO recommended. And Asia was probably one of the, is the region that went really hard on those measures, not only on restrictions, but on screening, on testing, and eventually on quarantine for travel. And this graph really shows how Asia was one of the the regions that really were most stringent in the use of those measures. But not alone. But Hong Kong, for example, when I say that every country did something differently, this is what made our project really complex, because we tried to track, okay, what did Hong Kong do? And what you'll see along the left side, and I don't think you'll be able to read it, but essentially it lists all the different measures that were adopted related to travel, managing the risk from travel. And it ranged from advisories to people from certain areas of the world cannot come in, to screening, to all sorts of things. And as you go along, you can see Hong Kong has actually maintained many of the policies across a very long period of time. So we try to map a few of the jurisdictions to just get a sense, and we based this on whatever data was available, and that's another story in itself. The data was pretty chaotic. But we compare it, say, with Canada, and you can see a very different picture just visually. You can see that some measures were adopted and went across the board, others were stopped and then started again, or they weren't re-implemented. And they were different measures. And if we did that for every country in the world, 194, we would have a different graph for every country. So coordination wasn't, as an understatement, was not part of the use of travel measures at the time. Everyone was trying to use their best judgment and so on. And we should add to this, there weren't just international travel measures, there were domestic travel measures. People were restricted in some areas of traveling within their own countries. When we think about Australia, we had some in Canada, some in Europe. Singapore is tiny, so probably didn't need to necessarily restrict internal travel, but other areas certainly adopted those as well. So that complicated the picture even further. So all of these measures, what it really came down to, and I couldn't find the headlines for Asia, but I imagine you had similar headlines, is confusion, is contradiction, and what is going on. People were given all sorts of policies. You can do this, but you can't do that. You can travel, but are you essential? Are you non-essential? Lots of different things, and it would change over time. So you wouldn't just say, okay, at this point in time, this is what I can do. But it could change even within your own trip. So you could get on an airplane, and this literally happened because I have relatives who work for Air Canada. They would let the passengers on the plane. By the time they landed, the policies had changed. And they no longer qualified to enter the place where they were heading to because they didn't do the test properly or something changed. So they're sent back. This is the kind of experience people had. And it, of course, made the headlines. People were feeling very confused and increasingly probably very frustrated. In terms of the evidence, this was also very confused. You have the New York Times saying that, the WHO said open borders would help fight disease because this is what they advocated. We need to keep borders open. Experts and a global treaty emphatically agreed, but the scientific evidence was never behind them. So there's now questions being asked. What should countries have done? Did this help? WHO was saying, we keep the travel going. Was that the right thing to do? And then others were arguing the evidence on travel bans for diseases like coronavirus is clear. They don't work. So you can imagine that these very prominent media outlets are saying very different things. And so the public is incredibly confused, let alone policymakers. What was the real, what is the truth behind this? And of course, we're having the pandemic play out very quickly. Things are changing, and everything's happening in real time. But it was a very, very confusing time for sure. So now we have, a few years since the pandemic, and can we step back and look at the evidence and say, well, what was the truth? Or is there some truths that we can find out? So what does the evidence say? Well, we can say that the evidence tells us that, yes, the SARS-CoV-2 virus was spread around the world by travelers. It didn't walk across borders by itself, right? The virus had to be carried by human beings, and it started, okay, I don't think it's controversial. I believe it started in China, but it eventually spread around the world by travel. There's, the genomic data seems to show this. And not only that, when new variants came forward, new variants of concern, they were also eventually transmitted across countries by travel. I think it's hard to deny that because, as I say, viruses don't just get on an airplane by itself. You have to have a person carrying that. So that's the genomic data. And it was a repeated introduction. Like people were still traveling and there were repeated introductions. And you can see these waves of, all the different Omicron, Alpha, and so on. So we know that happened. That is a very, for genomics researchers, that tells us. We also know that there was some benefit from some measures that related to travel. So this data really lists all the different public health measures that were adopted, and there were many, and what's the evidence on what were the most effective at reducing introduction of the virus into new jurisdictions and onward transmission. And what this study shows, and it is 2020, so it's very early, but it did show that there was a clear picture that social distancing, very, very important, but also travel restrictions. They were also very important. So I'll say a little bit more about that in a moment, but there was some impact and some evidence that that was effective. So this is also played out by studies in Australia. They modeled whether they, if they had no restrictions on incoming travelers, or whether they did not or they did, and what would have been the difference in terms of number of deaths. And the evidence seems to suggest that Australia did lower the importation of the SARS-CoV-2 virus by around 88% between January and June 2020. So they went hard on restricting inbound travel, and they have the evidence that that actually reduced it, the importations at the time. Singapore, of course, also did similar things, and other Asian countries. So it's hard to argue with that evidence. The challenge, of course, is COVID-19 was very prolonged. So when do you use these measures, and when do you need to adapt, and so on? So it's hard to maintain a lot of these measures. But it seemed to be, at least, there was some truth that the evidence had changed when you never use these measures unless you all have to, versus actually there's a strong case that maybe it should have been used during the early part of COVID-19. So there was a lot of systematic reviews of this evidence. They still are doing them, but there's not a lot of observational studies. A lot of it is modeling studies, and that kind of reduces the quality of the data, to be honest. Part of it is because countries did so many things differently, really hard to get comparative analysis, hard to get comprehensive data that you can compare across countries because of the differences in time. There's also gaps, of course. We didn't actually have consistent data about infections at certain times, different countries and so on, transmission rates. So it's a very complicated picture. The evidence seems to be very, very variable. We did a systematic review in 2020, 2021, and led by Karen Greppin at Hong Kong University. And what we found was basically that those countries that went hard or stringently early in terms of restrictions did benefit in reducing introduction of SARS-CoV-2. But that benefit was very time limited. So it could have been a week, could have been a few weeks, but it wasn't forever. So it's what you do during that time when you have that restriction. You have to put other things in place. And but that's still very different from saying never use those measures, never use those restrictions. So that was our systematic review. There was also a Cochrane review which said pretty much the same thing and was updated several times. And it found that Jacob Burns and colleagues found that travel measures can be effective. Context really matters. But there still needs to be a higher level of evidence to support this. So next time we need to collect better data, to be honest, more coordinated. And so there's a lot of things we still don't understand about this topic, even though, there was almost like a natural experiment around the world and what happened. There's still a lot of lessons to be learned. And so, what characteristics of disease outbreaks do warrant the use of travel measures? We would not want every outbreak to lead to countries reaching for closing their borders. That is not necessary. It really does depend on the pathogen that you're dealing with. So what are those characteristics that we need to think about when we do need to think about rapid and stringent restrictions or screening or whatever we can do right at the initial point of outbreak? So let's think about that. When is the optimal time to apply and lift travel measures? Well, I'm saying, the evidence shows very quick as soon as you hear about these outbreaks, but you may need to lift them as soon as you learn a bit more, so as information evolves. And imposing them for 3 years or 4 years is pretty hard. It's pretty hard on the population, so we need to think about how you then lift them. Which type of travel measures? I talked a lot about restrictions, but there are many types. There's quarantine, there's vaccination or immune-based certification. There's screening, like testing and so on. Lots of different, even masking, it could be a travel measure. So how do you use those? How do you use those in combination? And then what we didn't think enough about is the societal effects. What are the broader implications of using these measures for a prolonged period of time? They're not, cost-free. They impact your economy, they'll impact your society. And that leads us to having some ethical frameworks. What values will drive your decisions? It's not just the epidemiological data. It's going to be other things as well. And finally, is there a way we can sustain travel in our next pandemic, but do it in a safe way? Is it about immediately masking everyone that gets on an airplane? Is it about better screening? Is it about maybe restricting some forms of travel, some modes of travel, and not others? So how can we keep the world moving? So on that note, I wanted to just move into where we are at the moment. So we would like to think that, coming out of COVID-19, the global community has come together and go, oh, this is a really important topic. We need to revise the IHR. We know more now. Travel restrictions alone, we need to be a little bit more sophisticated. And I looked to the revisions of the IHR thinking, okay, this costs us multi-billions of dollars around the world. It impacted businesses, governments, people. Surely this is a priority topic. I did not see anything changed, and I was so disappointed. And I asked people, I said, this is like a no-brainer. This is one of the key things we need to fix. Why isn't there any change in the IHR? And they said, it was too political. We did not know how to change it to make it less political. People do not want their borders to be managed by other countries. And so they didn't want, IHR to have any more power to do that. And so I was, I got that, but at the same time, we needed to have a better collective action for that. So we wrote a paper on that saying, you know, you didn't change the IHR. Next time we have a pandemic, we're going to get chaos again because there's nothing has changed. We're not even, you know, we're not even a small step forward. So unfortunately, that's the case. The other way that WHO has tried to deal with this is to put forth better guidance on what they meant by a risk-based approach. You know, we should do a risk-based approach and then we'll get better answers or better decision-making. And they did put some guidelines together. But what we tried to do is, okay, a lot of people put guidance together on what risk-based approaches are. Many people understand it differently. They assessed risk in different ways. And so we looked at 11 jurisdictions or organizations, and they all assessed risk around travel differently. The methodology was all over the place. And so that was the point, that we need a global consensus on what we mean when we're, you know, thinking about risk. And I think that would help us. So that report is available online. And then we also need a better way of describing these measures. If you remember back, the headlines were travel bans, border closures, you know, all sorts of terms that actually were not very accurate. Because you would say, our borders are closed. Oh, but then you see people going through. Well, it's not exactly closed, is it? Because you have trade going through. Oh yeah, it's more like a restriction. And, you know, like you needed more accuracy, so that if we need accuracy because we need to compare like with like. If somebody calls it something else and someone calls this something else, and you're trying to compare, it's impossible. So we talked about having a typology to kind of find some better ways of thinking about this. And then we came up with a taxonomy of what do we mean. This, if we're saying border closure, this is what it means. Right? And if we're saying quarantine isolation, this is what we mean in terms of travel. So we have a kind of coding to hopefully standardize and describe what people are doing. So that was a lot of work, you could imagine. The other lessons we learned, and we're trying to improve the data set that's available, is to encourage people to think beyond borders. Travel is not just about when you reach your customs, you know, the person in the glass booth and give your passport over. It's actually what you do before you leave your home. It's how you know, are you going to get vaccinated? Are you buying your masks? Are you getting ready for your journey? So it's really the full journey. From the time you get in your Grab and you go to the airport, that you're traveling, you're moving. Time you get to the airport, you get on the plane or get on your train, you're going. The journey itself is important. And so all this time, and then before you reach border, a lot of that matters in terms of what happens. And it's also what happens after you cross a border. Do you quarantine? What do you do? You know, there was a lot of post-arrival testing, and then, you know, different countries did things differently. Sometimes some countries required you to go into quarantine for several weeks. Others, okay, hopefully, you know, we're asking you to go into quarantine, but, you know, we just hope you do, you know, sort of thing. So that was important to think about the whole journey. Also about levels of policy. So you had, it's kind of like that Swiss cheese model. It's not just one thing you do, but several things. And there's levels of jurisdiction. So what we do at the global level, we might have a general global system of vaccine certification or immunity certification that's recognized around the world. So you could just, like, you know, use it at the border and just show your credentials. Others, you might at national level, but also subnational level. So it all has to be integrated. We can't just have different things happening at different levels. And also think about those primary and secondary consequences. We often focus on introduction of a virus and onward transmission, but we have to think about those secondary and often unintended consequences. We collapsed whole areas of the society because we did not have travel. Tourism, you know, education, really badly impacted. And that over a prolonged period of time really needs to be taken into account. Is it worth doing if you're going to be doing that? And so we think about, you know, what are your priority populations? What are your priority areas? And when you think about risk, maybe there's areas you could target measures. Maybe it's really crowded buses or really crowded airplanes, masking. Or whether it's areas like very busy airports. Singapore is a very chunky airport. It's very big. there's like London Heathrow. There's certain hubs in the world that we need to kind of think about targeting. And so all of this brings us to our work in the Pandemics and Borders team. We have been trying to develop a suggested way of thinking about risk and travel, and hoping to, stimulate consensus around this. Can we agree a way of doing this? And I won't go through this, but other than to say that a lot of you who are remaining for the workshop tomorrow will become very familiar with this risk assessment tool, but it's really about starting, from the top, pathogen characteristics, jurisdictional characteristics. Think about those broader impacts, and then making your decisions around different types of travel measures. So it's a complicated decision-making domain, but if we can get better at it, I think we'll be better at doing what we need to do. So I'll just say that, again, this is a very sleeper topic. People think, oh, well, COVID is over. We're back to traveling again. Who cares? But there are still travel measures being impacted or being adopted for other diseases such as HIV/AIDS still, kind of testing. There's some for Ebola that were adopted. We can evaluate whether those were necessary and whether the secondary impacts are actually more than the actual benefits. And I would say, just to conclude, that this is still a live topic. We still are needing to have better understanding of what needs to be done. There will never be a one-size-fits-all. It will be a better decision-making process for sure. So I would just conclude with these key messages. Yes, travel was important during COVID-19. There's no denying that. And it did spread the virus around repeatedly. There was a fundamental shift in thinking about, first just using travel restrictions rarely and as a last resort, to thinking about how we can use it effectively along with other types of travel measures. We also need to think then about the evidence base for each country and for regions and globally, how to apply them, how can we improve that data? We still have so many modeling studies, but what we need is observational studies, really, real data and real world situations. And so taking these lessons, we can move those forward for anticipating those consequences that are broader and thinking about equity. That's some of the work that we're doing around equity and how we use these measures so that they don't disproportionately disadvantage those that are already disadvantaged. And I guess to skip down to the last ones, really we need to talk about very explicitly those norms and values that are underpinning these decisions. We were so often told, we're just following the science, we're just following the evidence. But clearly we weren't, because every country did things differently over time. So clearly the evidence was not just driving those decisions. And the evidence evolved over time as well. So the idea is to integrate evidence and ethics. And that would be really critical going forward around a risk-based approach. I'll stop there. I'm sorry if I went over a bit of time, but I hope that will stimulate some thinking on your part. I know this is a very diverse and experienced audience that's worked in this field. Many of you have had to make these decisions, and I really love to hear what your experiences were. But let me conclude by just saying thank you, and I look forward to our conversation.
I'll start by asking the rest of the panelists to give their take first, right? So all of you were involved during the recent COVID pandemic one way or another. I'd like to start from Mark with regards to what you felt or your reflections on what we did in Singapore with regards to border control, especially since Dato Chong is in here with us on the measures between Malaysia and Singapore. So for those of you who are overseas, Singapore depends a lot on Malaysia and vice versa. About 40% of all the fresh produce that we buy in Singapore comes from Malaysia. A third of our eggs and much of the manpower and labor, including for healthcare as well. And the causeway is one of the busiest transits between two countries in the whole world, right? So what are your thoughts on that, Mark?
Hey, it's okay. Just checking this works. No, first of all, thanks very much for this panel and very nice presentation just now as well. And just starting from where Liang left off, we have 300,000 people across our borders every day. So it's a lot of people coming in and out. And one of the things that we were talking about during the pandemic was actually what is a border when you have so many people crossing, right? It's almost contiguous in terms of our epidemiological risk together. But also going back to what was mentioned in the earlier presentation about ethics and evidence and how do we bring the two together. I think for Singapore, we did have a certain policy perspective in how we wanted to manage the risk of importation of the disease into Singapore. We were perhaps a bit more cautious than other countries in instituting things a bit earlier and then waiting for the evidence to show itself as being safe or not before we decide what to do next. So I think that was our perspective. We were also mindful that there was a bit of this fog of epidemic that was happening. Right? We weren't quite sure as to how serious the disease was, and we were trying to make policy based on what we knew of the situation and of the disease. Maybe just a few points on the perspective from a policymaker during that period. When we institute measures, and not just for border measures, but for measures in general, there's always an implementation challenge that happens with every policy. So if I want to institute temperature screening or testing at the border, I would need to work with certain stakeholders, but I also would need to find the space, I would need to find the people to test, I need to find quarantine facilities, etc. And being able to switch on and off measures doesn't come so easily. And you don't want to also be looking as if you're always flip-flopping, depending on what the epidemiological risk may be. So we know that there are periods whereby perhaps the transmission across the world was lower, but that didn't mean that we'll automatically switch it off because we didn't quite know as to whether this is going to be just for a period or whether it's going and when it's going to come up again or whether it's going to be a bit more prolonged. So that having to do a bit of predicting what's coming next, having to deal with the implementation difficulties, I think that was something which, as a policymaker, was quite important for us in making some of these decisions. And maybe just to talk a bit about vaccines component of things, in that vaccines itself does reduce the risk of the threat that we were facing, and so a lot of the measures there, whether it be domestic or borders, were really to buy time in anticipation for a more permanent or longer term solution to reduce the risk. Right? So I think that while we look at border measures alone, we must be mindful as to what are the border measures there for. One, of course, is to reduce the immediate risk of importation, but there was also waiting for the risk to eventually drop through the other measures that were, or the other science and tech measures that we were waiting for, or implement vaccines that would be able to help to do that. And I must say that the role of WHO, in the future, especially in deciding how the recommendations would come up and how countries would implement, would be important to think about. Sovereignty is quite important to many countries, so I do think that they do need to balance between clarity and based on the science that has emerged during this inter-epidemic period, but also knowing that the countries do want sovereignty to be of an important issue. Thanks.
Thanks very much, Mark. And maybe let me just turn over to Datuk Chong on your reflections and how Singapore's relationships at that time with you were affected. I know there was a Singapore Joint Working Group set up very quickly to deal with the issue of borders and transit between countries.
Thank you very much, Prof Lee, and good morning to all my fellow colleagues on the chair panel, as well as to all my colleagues sitting all over the room. Well, first of all, I must say that I'm happy to be invited here by Prof, and he told me to share all my wrong decisions that I've made over the course of that time. But
that's surely not true.
But I shall deny any responsibility for that actions. But first of all, on a serious note, I'm very happy to see among the many faces that I know, Dr. Derek. Derek is the head of public health in Singapore, and I work very closely with him during those days. And of course, we have Jeffrey and a few others. And on the medical side, I'm so very happy to see Prof Leo. She worked very closely with our ID physician, Dr. Christopher Lee, and of course the many other people that we have contact in off and on. So the thing is that I won't talk much about the theory behind it. There are many experts in this room. Prof also have mentioned a few of the theories. I would like to share a few things that happened between Singapore and Malaysia, as well as I see my Thailand colleagues, also some of the things that I have with Thailand as well. So start of my story is actually Chinese New Year. Very interesting. I was having my reunion dinner at home around 6 o'clock, just about to enjoy my dinner, when I received a phone call from my friend there, giving me bad news. He said, Chi Keong, I'd like to inform you that we're going to make an announcement in 6 hours that positive COVID, we don't call it COVID-19 then, we call it something else, I can't remember now. We have some patients for you that we have diagnosed positive. My first comment to him was that they keep them in Singapore. Why bother to send them over to Johor? Keep them there. Right? Travel restriction, keep them there. But it says too late. We already let them go. So they were on their bus to Johor. Thank you, Derek. I still remember you for that. So they arrived in Johor, and of course we had a lot of things to do in terms of the measures we have to take from that day on. But the main thing I would like to stress is that as the things progressed, we closed our border, and that's where the discussions was really intense. Malaysia, Singapore is the busiest cross-border channel in the whole world. At that time, it was 300 to 500,000 cross-border travelers at that time. And most of them are for economy, to work in Singapore and then to come back after the day is done. So once we put that in, a lot of happenings need to be discussed. How will the industries in Singapore perform? And how will the people who are earning a living in Johor will perform? So we had a lot of discussions, and then we have to work out, okay, shall we do this, shall we do that? Now, for countries that are more richer, it was not a difficult decision. So Singapore decided to put everybody in a hostel. They the employers probably rented those hostels and let our workers, stay there. And for certain countries, say like Europe, America, they go on something called furlough, where they are paid their monthly wages. I'm not sure how much of a percent, but they were paid. But in poorer countries like Malaysia, please remember that, we don't pay anybody. After a few months, we just give them like 200 ringgit a month, which is not even enough for one person to survive, let alone a family. So a lot of things not directly related to health, but was starting to creep in. So that makes decisions like closing borders, travel restriction, very, very difficult. And also, we have to talk about patients. How do we treat patients across borders? Now, I'm not sure what your experiences are across the different countries here, but we even deny patients who are positive to enter our shores when they are already literally in the sea. Ships were infected very badly, all those big ships, cargo ships and so on. So they land in Asia, in our region, and the poor ship has to go traveling from, say, Cambodia, Vietnam, Thailand, Singapore, Malaysia, looking to treat patients. No single country at that time was willing to treat those patients that are on the ship. I remember there were a few, since we're talking about Singapore, foreign ships who arrived in Singapore, and they were not allowed to land for the treatment of patients. And of course, after that, they have to contact Malaysia because it was the nearest. Unfortunately, the decision was not mine, although I took part in it. The decision was not allow them to land and not allow them to treat their patients. So they went up the coast. One of our ASEAN member states actually took them in, so I'm very proud of them. So these are the issues that arose in terms of patients. And then we have to decide with Singapore, okay, in case there's a positive Malaysian patients in Singapore, how do we send them back and vice versa? So a lot of things have to be negotiated in a way that both of us are comfortable. So I think the main thing in terms of travel borders across countries will be the expectation of both countries and willingness to work together. I think that is utmost important. There are a few other things, but I shall stop short for now. Thank you.
Great. Thanks very much for your insights and recounting of the Singapore experience, Dato. and now I turn to Bo. I was struck by a slide from Professor Lee's lecture, which said that we make evidence-based policy, but it turned out that there was no hard evidence. And a lot of it was just modeling studies, right? So maybe you could defend.
So on that note, right? Absolutely. So whereas a lot of people were on the front line actually dealing with it, we were pretty much locked in a room in the dark with no data and told, make a model. And we were like, okay, we can do that. We can model until the moon falls out of the sky and crashes into Earth, but I have no idea really what's going on out there in the world, right? We have a very myopic view as modelers. From very limited data coming in, we have to try and infer what to do. So what ended up happening is that we had to model pretty much everything. So we modeled cargo ships being potentially stuck at sea, like what kind of screening, what kind of testing could we do for the workers, when do we test them? We also modeled at the border who to test, how long to quarantine, when to quarantine, how many cases we're going to miss. But it always came down to, as a modeler, that we would say, so what is your risk appetite? And that one was so different for every single country. So for Singapore, I think at the start, it's a general feeling of like none. We're going with no cases. We're going to be super safe on that side. And then as the outbreak evolved, we were like, okay, maybe 1, 5, 10. And then we would, as modelers, say 50, 500, 5,000, 10,000. And it always became this bar that kept changing. And because of that, our border controls kept changing. Now, the other thing I'll say is this was a big issue among the modelers because it's so highly politically charged. We would often reach out to collaborate or to foster collaboration, and it was rough. Like a lot of other modelers were like, we're not allowed to share our results. We're not allowed to even talk about what we're doing. So what ended up happening is that we had to model pretty much everything from Singapore's sort of perspective, and then also try and infer from publications what was going on in other places, and then from us adapt to that, and then try to almost secretly work with a lot of people without getting a lot of big media involved to try and understand how to protect borders, because we can model from Singapore out, but the reality is we need models that model everybody at the same time. Because a lot of people, sneaky people, and some of us are definitely in this room, found ways to skirt around some of the border controls, right? And, there was also a lot of people breaking rules in a lot of other countries. I won't say Singapore so much, but I'm sure people did, which meant that a lot of the border controls were ineffective because people were not abiding by the control measures that were in place, right? And so what that meant was that Singapore had to adapt after that happened. Let's say country X, which shall not be named, was not doing its job and actually had loads of travellers coming in with much higher prevalence than we predicted. We were too slow to react to adapt to that, which meant that a lot of cases came in despite our control measures because we were not modelling the right thing. So one thing that we called out after a lot of the modelling work was done was to say that there needs to be a core modelling team that basically works without borders. That we basically work very sort of agnostically to say, okay, let's do a border control model where we have all these flows. And maybe now we can do that with the bigger models, with genetic models, like ones that are fed data, huge data. And we have a lot of travel data now, and it's not so sensitive now. So I think now is the time that we need to build the infrastructure to have these big, huge global models. And I know some groups are now working towards that, where we can react to perhaps the next big outbreak. I mean, we're very concerned about avian influenza. We're not going to live in a world anymore where outbreaks are limited to locations. Even things like rabies, we really don't have a protocol in place of what to do when we get rabies. So that's something else we're working on. So One Health is sort of the next question mark, and the next respiratory outbreak is another very big question as to what are we going to do. Yeah, so that's all from me.
Great. Thanks very much, Bo. And there's already been a list of questions coming in on Slido, so maybe I'll ask 2 of them before I open up the floor to those who might want to ask their questions in person. You have listed some of this, Professor Lee, but the question that comes in is then, what are the most urgent evidence gaps that should be addressed before the next pandemic, especially with regards to this travel restrictions and borders issue?
Yeah, that's great. I have a microphone on still, so I'm good. Thank you. Thanks, Phil. Yeah, that's a great question. We've talked about this a lot. We wanted to write up a paper on, what are the key evidence gaps. I think just standardizing how we talk about this is a good starting point. The terminology was all over the place. I think we're getting better, but it's still very emotive language as well. And it's wrapped up in, rhetoric that's happening now around human mobility. So this is, just separating out, being very clear what we're talking about in terms of the flows of humans across the world, but also the measures themselves. So we can have like a very standardized, and that should be easy to do because that's not like so loaded, then we would then need to measure, have clear data to measure who's using these measures and how they're using it. So we need a kind of stringency framework, which we had with Oxford developing a stringency framework, but it was always very limited. So we need to blow that out and say, okay, if we want to use restrictions, there are like gradients of how we use that. And we need, we sort of have kind of, these are kind of conceptual things, but a framework to standardize that. And then if we do have measures used around the world, and they are still being used, it's not just for COVID-19, it's for all sorts of things, let's monitor those countries and see if they are actually making an impact on public health goals, but also what are the wider implications. So I think we could gather that data and learn on an ongoing basis. We don't just have to keep looking back to COVID-19. And then finally, I think, there's a lot of data gaps, but when an event is happening such as that, we were gathering data differently across different countries and not sharing, as you said. And that is a big problem. So how many people are arriving? How many people are tested as they arrive? What are the results of that? Why is that so secret? We need to know that in order to help the modelers to have better data. We have to inform real-time decision making. And so if that's the model we're going to use, is that, based on how many people are coming in and being tested and so on, that's really important to share that data across countries. It's an evolving situation. So real-time data collection, I would say, on all sorts of epidemiological aspects would be really critical as well. I mean, there's such an arm's length of data that we could have used at the time, and I guess people were extremely busy and under siege. So I get it, and it was so unprecedented how travel was being managed that I forgive people for it being such a mess. But I don't think we should make the same mistakes again. I think we could do a lot more. It'll never be perfect. Policy is never perfect, but we could do better.
Thanks. And maybe from Bo, since you're holding the mic, from your perspective of mathematical modeling, then what are the things that we should develop and what are the gaps that we should have? Because I remember during that time, there were all kinds of models that had really divergent results. Even in Singapore, which is so small, we had some multiple models that showed different outcomes as well.
Yeah, for sure. So I think policy reviews are absolutely essential. Ensemble models, where we have a whole bunch of people doing different models and we all compare results and we find out what the differences are. That's one of the things that we should be doing. The other thing to note is, so we recently did analysis on chikungunya and the outbreak in Foshan, which was pretty much unprecedented this year. And we know that perhaps there's links with Reunion Islands outbreak. So we're always slow to react. So there needs to be more preemptive outbreak modeling, more like risk management, and then understanding when an outbreak is happening in one place, a country needs to be open about that to the point where other countries can say, okay, we need to be wary, not necessarily travel bans, but we need to be aware so we can take the necessary actions from the other side that we can minimize that risk. And of course, it's not perfect. We're going to have cases, we're going to have outbreaks. But the thing is, we shouldn't be left to a point of reacting, because then it becomes a matter of almost emergency management, and that's something we'd really like to avoid. Yeah.
Thank you. And now I guess a question for Mark and Dr. Chong. How does fear influence policymakers and the population during uncertainty, and how should we address this? Because you advise the people who make the decisions, right? And so what are your thoughts on this?
Well, so first of all, I think fear or uncertainty and worry of not knowing what we're dealing with it's a natural reaction that people would have, and I guess including policymakers in wanting to make the right decisions, right? So it's not something that we can just wish away and say that we're not going to have it. I think that knowing in advance what, and I think the issue again, ethics, or rather almost a social contract with the people and what is acceptable would make a difference. Knowing how much evidence there is out there and what we know or do not know, and communicating that early would make a difference. Because rather than leave everything ambiguous, we can then say that this is what we know, this is what we don't know yet, and then we will adjust as we go along. But based on what we see, this is how we feel that we should best respond. So I do think that recognizing that the uncertainty will be a problem in a pandemic is a start. and then using the evidence as far as possible and communicating that and making the right decisions based on the evidence is perhaps one way we can get around it.
Thank you very much. I think fear actually helps us make decision fast, not necessarily the right one, but it helps us make decision fast. So a lot of decisions were made at that time based on fear. What if we suddenly have thousands and thousands of cases and no ability to manage them? So we close the border. What if we have no medical ventilators and so on? What should we do? So we order like thousands and thousands of ventilators that end up just being stored there. So it helps us make decision fast, but sometimes the wrong decision. Hopefully, we can address it in a more rational way. But depending on the degree of the danger we perceive and the fear we feel, it actually drives us to make wrong decision. But one more thing I'd like to add is that the decision that we are forced to make sometimes doesn't come from people who are relevant in this field. When I say relevant, they are not even related at all. So without trying to say too much, otherwise I may not be able to get back to my border. We are forced to make decisions because they say that you will be responsible. What if this happens? What if everybody start dying? So those are important decisions. Here again, I just like to point out to give a shout out to Dr. Tilaka. She's the WHO pandemic in charge person. So I like to say that there are a lot of things that I don't agree with WHO, but in the area of no border control or not recommended, I think I can actually see it from their perspective for another time. Thank you.
Thanks very much. Now I'd like to open up the questions for those of you who have trouble getting into Slido or haven't asked their questions. Is there anyone from the audience here who would like to make a comment or have a question? Yes. Please introduce yourself before you ask the question.
Thank you. My name is Harrison. I'm actually a research assistant professor at the Center for Biomedical Ethics. So my question is related to the political authority of public health agencies today. So I think historically public health has drawn political authority from the technical expertise. And that relationship seems to be waning today. Going forward into the future, what do you think public health as perhaps a community or as an entire body, what do you think they can do to perhaps regain some of that political authority? And I think this political authority is important because we're talking about borders here. We're talking about international cooperation across borders. So what are your thoughts on that? Thank you.
Is there one of you who want to take on this question?
I can start. Maybe this is an area where I'm working on with another project that I'm leading on vaccines and public trust. And we know that COVID-19 really shook up how people see public health. And I think generally that there's been a decline in trust in public health institutions and public health experts. And it goes wider than that. And so we have to reflect on, I think somebody mentioned the social contract. That's really fundamental. I think it was you, Mark. Fundamental starting point to not just political authority, but how people perceive who is legitimate to rule them or to govern issues such as this. And so we're in a kind of really, I think, concerning time for public health, but I think broader in democracies, about how much people buy into the social contract. I often say public health, before the pandemic, we were seen as the good guys. We were always trying to do good, helping people to live their best lives, health and well-being. No one kind of, if they might ignore us, but they wouldn't necessarily have negative thoughts. And now it's really difficult. If you're out there and you say, I work in public health, you're not sure how people are going to react now. And often you're seen as the bad guys because you took something away from people. And so I think there's lessons there about having to anticipate, that there are wider consequences. It was so well intended what public health officials around the world were trying to do. From they'd seen the public health challenge What they were perhaps less able to recognize is those wider social impacts that really then turned people in a prolonged event away from those public health measures that were so well intended. And that's a real tragedy, and we need to explain why those measures were taken and then take account of those wider secondary unintended consequences much better. And that's, I guess, what our project is trying to do, is try and see a more holistic, whole of government, whole of society approach to pandemics in the future, which I think most people would recognize. This was not just a public health emergency. This was a societal emergency, a global emergency, impacting everyone's lives. Most people impacted by COVID were not patients. They're just people. And so, yeah, being able to, I think, acknowledge that in public health, and then I think over time, to build that legitimacy and that authority again. But it's going to take some time to win people back, I think.
Great, thank you. Yes.
Yeah, thank you very much. I think I don't really agree with that comment that the political people are, not really taking considerations of our recommendations. I'm more in the line that public health is now very much higher than it was, say, 30 years ago. Nobody even know what is public health 30 years ago. But after COVID, everybody knows. Now, in terms of what we are talking about, huge decisions like political borders, huge decisions. What I understand and experience is that when you have to make decisions on small things, where the impact doesn't cross beyond certain social norms, doesn't affect the community, doesn't affect the small organizations or the individuals, it's easy. Your minister or relevant people will listen to you. They will take our advice. But when it interferes with the borders of the rights of other people, like you're not allowed to come out of your house to do your business, because then it interferes with the responsibility outside of public health. So if we were to say border closure, right? 300,000 people from Johor cannot go to Johor, Singapore to work. Who is going to feed them? So when you make such a decision, you cannot expect the political people to just agree to you and says that, saving this 300,000 people is important. Their question is, these 300,000 people, maybe one or two will die. 299,998 will survive. So who are we to say that we are right in that sense? So I don't really think that, I really think that public health is very much at a higher level. We are actually exerting more influence than we have ever before. It's just that sometimes it would be good if we can work with other people. Sad to say this for myself, doctors always think they are God, you see, even outside the perimeters of the hospital. We think we know best. But I sincerely doubt that. Thank you.
Great, thank you. Another question from the floor?
Yeah, thanks very much. My name is Gwen Emer. I'm visiting faculty with the Center for Infectious Disease Emergency Response. And my question is really thinking about kind of tipping points, specifically in the context of resource-constrained environments. Do you have sort of either evidence or thoughts and feelings about what makes border control a good idea versus a bad idea in the context of having limited resources that you choose to either allocate to this or to something else? I'm thinking specifically, I worked in Congo during Ebola. There was a massive PCR testing regime, let's say, to get into the country, at which point people are dying of Ebola and malaria. And so sort of thinking about the trade-offs of, in a resource-constrained environment, do you do this, do you not, and how do you decide whether this is a reasonable thing to be doing with your time and your resources?
An important but very challenging question. Is there anyone here who would like to try?
Give it a shot. So yeah, completely with you on this one. So we're currently working on Mpox. So we see some of these exact like resource constraints. We did vaccine allocation across the region there. So that's an excellent question. And during the modeling for the border control, that was the exact question we asked. Let's say we've got this many vaccines. Do we give it to the local population or do we give it to travelers so they can travel? So it came a much bigger question than me. So I could say that this is what happens in the local context, the local outbreak, this is what happens to your travelers if they go. But the question comes, how urgent is that travel? If that travel is going to be responsible for bringing X amount of money, which then goes into the Ministry of Finance and all these other things, versus that trade-off knowing that an individual in this community will not get a vaccine, that's a huge question. That comes down to ethics and all these kind of parameters which we couldn't model. But absolutely, we should be modeling that in any context of border control, where there has to be a sacrifice, if you will, from one resource being translated to a different context because of the different demands in place. That one has to be modeled from our side. That's all I can really respond is I'll model it for you, but the outer context requires people such as yourself and all other experts to say, well, okay, I understand the numbers, but that's a stupid idea, right? So this kind of feedback is really important for modelers, yeah.
Thanks. Maybe either Dr. Chong or Mark, because I think while we talk about public health and the impact on public health, there are a lot of other considerations once it becomes a big outbreak and impacts on the country's infrastructure, economy, and stuff. How do you make a decision in the trade-offs, or how do you recommend those?
Thank you. So I think I would directly try to focus on the question, which is resource constraint. So Bo here has already talked about resources in terms of finance. So if you're a resource country, you only have so many dollars, where are you going to put the resources? So this is actually, I think, right on the top. Where are you going to put the resources? So I do agree with that. The other thing would be, of course, to talk about the surge capacity. Because when you're a resource country, a lot of indirect resources are used. For example, volunteers. For example, utilizing social how we got it? Mobilization, companies, and so on. So the decision to be made in Africa, for instance, if you are in charge of a poor country like Congo, right? You have only that much of money, as mentioned. There's no way you can do extra testing. But what about your, in terms of country, your international mobilization? Would you allow Red Cross to come in? Will you allow, other countries to come in? So those kind of resources also need to be considered, and not purely from the aspect of the Ministry of Health or the government of, say, Congo. Thank you.
Thank you. Mark, do you have any?
It's fine. No, just to say that actually, going back to the comment earlier about there is the modeling and there's the evidence and there is the quantitative things, and then there's a whole bunch of other policy layers, political layers, cultural layers that layer on to how a decision is made in general, right? So when it comes to resourcing, I suppose, yes, the public health side would then say that, this is the impact and this is where we think the resources will be allocated. But being able to have a conversation with all the different stakeholders to see the different views may be also essential, so that a final decision can be made as to where it might be. So from an outsider, we may look at the decision and say that we don't understand why resources are allocated in such a manner, or a decision is made in such a manner. But if a decision is taken well within whoever's making the decision, then all the aspects would have been taken in to come to that decision. So hopefully that would then at least, allow for whatever allocation is best.
Let me push you a bit on that, Mark, because then when we take a stance like that, obviously you're going to have different policies coming out from different countries, which kind of makes Professor Lee's work challenging. But at the same time, then how do you assess that policy and decide this was a good policy or this was a good thing that we did? And how do we learn from that to move on, right? Because these things are always going to change all the time.
Yeah, so I don't have a clear answer to that, so I'm not sure whether the academic side to it. But no, so the question really is, what is considered a good impact or outcome from the policy that has been rolled out? But what's our measure of effectiveness? Is it deaths averted? Is it infection numbers that we have managed to flatten the curve? Or is it in terms of the livelihoods that are affected? Is it in terms of economic outputs? Actually, there are many ways in which we can then judge a policy to say that this was a good decision at the end or not. I think the challenge is that that's always after the fact, right? And in policy, you have to make, policymakers will have to make a decision not knowing often how things would pan out. And you had that diagram just now to say that there are some things that are unanticipated, right? So there's a whole space of unanticipated consequences which we may not be able to know, especially if it's a new, never tried out before, which was the case for COVID, unfortunately. And we'll just have to see how that turns out in the end. So I do think that when we look at how policies were made, the outcomes of it, and we try to then say that in the future, will we have done the same? We do need to be a bit, forgiving, if you may, to then know that as a policy develops, it's not always that you have the full spectrum of knowing how everything will pan out. You will have perhaps some data points, and then deciding from there whether or not you will still take those decisions in the future. But knowing that, again, the consequences are not just about health, it's about economic, it's about social, it's about cultural, etc. Yeah.
Thanks, Mark.
If I may jump in, because this is a really important question, and I like Mark's response. I also like how others have talked about trade-offs, because it is fundamentally about trade-offs. There is no one way or one best way to do it, because your country context is going to be very different. So Congo is going to be very different from Singapore, obviously, in terms of the options, but also the policy goals. And so I single out, for example, Vietnam. So Vietnam decided that the healthcare system was not strong enough to withstand a very large influx of COVID cases. And so they went very hard on border management restrictions. And for them, that was the right way to go, because they wanted to protect that, that the system that would have been very heavily impacted. If you have a very strong health system, you think you could, have a good surge capacity, you may not go so hard on those measures. New Zealand is another case where a very high-income country, but decided to go very hard on borders and had good high-income, high capacity, but wanted to protect the society. So they kind of insulated themselves. And you see people going along with their regular business. People couldn't get in, of course, or were very, very restricted, right? And even a lot of people couldn't get out. But they had that bubble, which they maintained. So that was a choice they made. What did they prioritize? And every country has to do that. We just have to make sure that we involve people in our decisions. We take account of context, and available resources obviously is really going to limit what you do. So there isn't one way, and I think you're right, having that broad perspective and being clear about what your goal is. It's going to be different for different countries, but I think that's the way forward. So I think for Congo, unfortunately, there was this very limited capacity to do much. I think I just don't know, imagine what options were available, but the context, all that would need to be very quickly assessed.
Very sensible. Bo, I think you wanted to add something.
Yeah. I actually have a question, and this one can be for anyone. So let's say we receive a traveller from the DRC or from any other country. Who is responsible for that traveller's costs and care when they arrive in the country? So for Singapore, is it Singapore, or is it from the country of origin? And that was a long ethical debate which still rages on today. Who is responsible, the origin or the destination, for the welfare of that traveller? Yeah.
Depends why they were traveling, and I think their citizenship. I think so some countries would charge the traveller if they were non-national or non-resident. Others actually covered the costs, but over time, the costs were so high that somebody had to cover them. Also, you had to restrict the purpose of travel, so you had to be an essential traveller. What that meant varied from country to country. But even essential travelers, if they were business people, had to pay their own costs.
So then the topic of insurance really came up, right? That you had to have COVID insurance, and then a lot of people couldn't afford that, and a lot of resource settings couldn't afford the insurance premiums to send their essential workers.
This is where the inequity comes in.
Yeah, and this one, I still, to this day, I don't have an answer, the models to how to address that. Yeah.
Yeah. Just to add on that, quite a few countries under infectious disease, and talking about infectious disease, treatment is by the state, not by the individual. A lot of countries, I wouldn't know exactly which one that doesn't. So like in Malaysia, probably in Singapore, if you fall under infectious disease, the government will take care of you so that you don't spread to the population.
So then that would be the country's destination, moral and ethical responsibility to treat you?
Not ethical, by law.
By law?
By law. But I'm not talking about every single country in the world.
Yes, that would be the question, like other resource poor versus when does it become
That's a good question.
Great, thank you. So let's move back to the Slido questions. This got bumped up, right? It's from Polian. How do we develop more flexible risk assessment frameworks that take into account contextual differences across countries, fragile health systems, demographies? I guess must mean on a regional level or international level. Do any one of you want to?
That was the model we showed, which is our attempt at it, and that's changed a lot over our 5 years. We played with that, and Julia will know, and Miranda will know. It changes even to the point of coming this week, because we wanted just to be more comprehensive. So the things you take into account, and so tomorrow when we practice using that risk assessment tool, let's test to see if it's useful to we have 9 countries, I think, who are participating. I'm really keen to see how you make out with that. But there isn't one at the moment, and I think this is where WHO actually could step up and convene. And this is what WHO is very good at: is trying to find consensus around tools and guidelines and these kind of normative frameworks. And we don't have that at the moment. We have some guidelines, and as I say, we identified at least 11 different ways to do it. I'm sure there are dozens of other ones. We need to land on at least a broad framework that's more comprehensive, which doesn't exist at the moment. So we're going to put it out there and test it on you 9 countries that are here, and then take it forward. We're going to be going to Geneva and Ottawa, and then we'll write up something and try and maybe suggest WHO could take the ball and run with it.
Okay, Pauline, so if you are listening to this, then we'll make an exception and you can join the workshop tomorrow to find out in person.
Please do.
Now we've only got 5 minutes more to go. So I'll stop the questions. I'd like to open to the panel. Maybe you have any thoughts or final reflections that you want to share. Maybe we'll start from Professor Lee and then we'll go down the line.
Yes, well, I really appreciate the audience here in Singapore, because I would say, Singapore was really interesting. The region was really interesting, and we watched countries and how you dealt with travel, having the experience of SARS-1, MERS, and a number of other outbreaks in the region really probably put you in a good position to think about this much more quickly. And I think that reflected in how governments behaved. But no country was perfect. There were relatively good performers, relatively poor performers, not so much in Asia and other regions. But I think we can learn from all of them. And, having that, I think a global data set, and we've been working on this really hard, to try and pull lessons across countries is the way that we can move this forward. And hopefully we can share some of our findings as we write up a lot of this work in the next few years.
Thanks. Mark?
I was just reflecting on what Dr. Chong mentioned earlier on the communication that had to happen between countries bilaterally, when there's a border. And nowadays, because of flights, right, there's essentially permutations of different borders because you can just fly from one to the other. But having that conversations, I think, are important, especially the ones that are very adjacent, because the agreement on what your shared policy goals are would actually help to have common understanding when a crisis happens, rather than wait for something to happen and then try to figure out what are we going to do in this case. I think for us, we have 2 main land border crossings, and those are bridges. Can you imagine if we had a contiguous land border and 300,000 of people crossing, a contiguous land border? It would have been a very different context and discussion. But it happens across the world. Many people have contiguous land borders where undocumented crossings happen all the time. So I do think that the context is important. And I do think that discussion is important as we work on the science as well as the frameworks to think of how we make these decisions. Thanks.
Thank you very much. I think a lot of the questions wouldn't be answered, but at least will be dealt with tomorrow during the workshops on different aspects of things. My last comment probably will be that if we have to do it all over again, especially if the duration is long and with internal movement restrictions, we really need to get the social and economic perspective side by side with health, and not just with the health perspective alone. Thank you.
Yeah, thank you. It's been very interesting to also hear from my fellow panel members all the interesting insights today. So I think my take home from being a modeler at the time is that we need to look forward. Right, what we learned from COVID cannot stop here. We must now start building the next sort of generation of models, which are going to be more for pandemic preparedness rather than pandemic reaction. Also, welcome anyone who wants to work in that field. Hello. So yeah, we love modeling. That's what we do. But of course, we are always a tool. We're always the numbers people. So that always has to be put in the context of many other aspects of man. And that's something I think that was neglected during COVID-19, that it became a numbers game. And I think it can never be that way, and it should never be that way. So yeah, with that, thank you.
Great. Thank you very much. Please give a big round of applause to our panelists.